My name is Dr. William Santoro, and I am the Chief of the Section of Substance Abuse Disorder at Reading Hospital. And I am an addictionist, board certified in addiction medicine as well as family medicine. And I treat patients with all sorts of addictions from opiate to cocaine, alcohol. And I'm the medical director at New Directions, which is a methadone maintenance treatment program, as well as treat people as an outpatient in a private office. We're going to talk about naltrexone, the use of basically Narcan in the emergency setting of an opioid withdrawal situation. There's been a large increase in the use of opiates recently. Much of it has come about since we now have better medications to treat pain, and these medications are in the family of opiates. And with that, they've become more accessible to people they shouldn't be accessible to. Patient goes in to see a doctor for a legitimate medical issue and receives opiates. Like most people, we don't like to throw away things after we've paid for them, and that prescription may end up in their medicine cabinet, and later on, unbeknownst to them, a younger child may get access to it and think, well, if my grandmother had this, it must be safe, and I hear it's fun to use, and so begins the problem. So I think it's important to educate not just the people who are at risk of using, but also the people who might be the ones who obtain the medication legitimately, and that use is being diverted unbeknownst to them. Opiates are medications which come from poppy seed, from the poppy plant, and there are several different types. You have natural opioids, you have semi-synthetic, and then fully synthetic. What these products do is they attach onto a certain area in the brain called the mu-opioid receptor. And once it attaches, it activates that receptor site to the point that, if being used appropriately, reduces the person's pain. If being used inappropriately, will give them a high. After a few hours, these receptor sites become free of the opiate, and the person comes back down, or the pain comes back into play, and then the person takes it again. The problem comes in is if the person then keeps repeating that in order to get a buzz or a high, then what happens is it habituates to it. And now when the receptor site is freed up, instead of going back to normal, the receptor site has been deformed, and it basically is clamoring that it needs the opiate back. So the patient has become tolerant as well as dependent on it. What can then happen is if a person has been using their opiates, say obtained from a relative or a friend, many times what happens is, or even a doctor, a patient goes to see a physician and gets an appropriate medication, and then the medical condition is now no longer an issue, but the patient continues or wants to continue to use the opiate because they are becoming dependent on it. They'll then turn and buy possibly the same prescription or a similar prescription on the street, which is available. Oftentimes what happens is the prescription is no longer available, or the cost is too high. Heroin today is much cheaper than it had been, and it's definitely a lot cheaper than some of the prescription pills. So in an attempt to alleviate their withdrawal symptoms and to still be able to get their medication or their high, they often will turn to heroin at that point, either snorting it or even injecting it. A physical sign of a person who is now abusing any type of opiate can be anything from just bloodshot eyes to feeling dizzy, falling asleep, being fatigued, weight loss. The problem is that all of these symptoms are very nondescript. So a person who has the flu could have very similar symptoms. You also have some behavioral changes that can come about. A person who is no longer enjoying the things they normally enjoyed, their relationships are changing. Parents will just usually describe, something is changing in my child. If it's a 16-year-old, many times, again, we get confused with a normal 16-year-old developmental behavioral change as opposed to a sign or symptom of opioid dependence. So people need to be vigilant. Not every one of these signs means somebody is using opiates. It could be something else. On the other side, don't be so quick to write it off as, oh, it's just a 16-year-old behavioral and we'll grow out of it. The problem that we're looking for when a person is overdosing is the fact that there's going to be a respiratory depression. And when respiratory depression kicks in, the person, by definition, stops breathing. And now we're talking about a medical emergency. Respiratory depression isn't the first sign of the overdose. Nodding out would be an earlier sign. So a person is trying to get high, they're feeling the buzz, they're obviously going to be very sedate and mellow. And that's the high part that they're looking for. When it crosses the line and now the person's breathing is slowing, the heart rate is slowing, the breathing stops, the person will now start turning different colors, ashen, ultimately blue. Other signs of an overdose, impending overdose, is vomiting, and aspiration pneumonia is also a risk of overdose. So as the person relaxes and then they vomit, if they're lying back, the vomit is still in their mouth and they're still not at the point of respiratory depression, they breathe it in into their lungs. Then the final step, of course, would be the respiratory depression to the point of stopping. Anyone who uses an opioid is at risk of an overdose, of course, by its definition. But there are other classes of people who would be even a higher risk within that group. Okay? Obviously, if somebody never uses an opiate, they're not going to be at risk of overdosing. So by definition, it's a person who's using an opiate. But within that group, the higher risk population would be a person who recently got out of treatment. So you could almost make the argument, partly tongue-in-cheek, saying that a person who goes through treatment is at a high risk of overdose. It's kind of counterintuitive, but the reason that the person who goes through treatment is at a higher risk of an overdose is their tolerance has now been diminished. Okay, so a person whose tolerance is diminished and goes back to using, a lot of times they go back using thinking they're going to use the same amount they used before. And because their tolerance is now lower, they overdose. Another group would be people who were recently released from prison. Or a person who just got caught as a teenager and had an intervention with their family, and they're at a heightened awareness of, I'm not going to do this. But as they move forward, again, their tolerance is diminishing if they then relapse. So thinking of a person who's relapsing as opposed to actively using, relapse is going to be a higher risk of overdose than a person who's simply actively using.
But once again, anybody that's using.
But anybody who's using. That's the overall risk. Anybody who's using is at risk of overdose. Within that group,
How someone could obtain approval. Well, explain what naloxone is.
Naloxone is an opioid antagonist, a pure opioid antagonist, meaning that it's going to still attach to the same receptor site, the mu-opioid receptor that the opiates attach to. But instead of activating, it's going to be zero activation. Okay, so it attaches with no activation, so there's no response to it. But at the same time, because it is attached to the mu-opioid receptor, that receptor is not available for other opioid agonists, such as fentanyl or OxyContin, Roxys, or Percocets, or even heroin. The mu-opioid receptor will not be available for those products because the naloxone has attached to it. It will come in, and if both products are there and you have one receptor site, the naloxone will attach and it will not activate. So if the person has been using heroin and is high and you give them naloxone, they immediately lose the high and go into withdrawal. Taken to the next level, If the person has been using opiates and is overdosing and they stop breathing and the person now gets naloxone, the naloxone will displace the opiate from the receptor site and the person will now have a better chance of breathing and reverse the overdose. It's not a complete cure. Person who is in the midst of an overdose receives a dose of naloxone. They may start breathing, they'll come out of the overdose, hopefully, if that's working the way it should, but it doesn't stay that way. The naloxone has a half-life where after about 30 minutes to 90 minutes, that is coming off of the receptor site. And as that comes off, the opiates that are still in the system will go back onto the receptor site and put the person back into a state of being high, or most likely back into the state of being in an overdose. So the treatment is not the cure. The treatment buys the time to go get medical attention. What's going to happen is that opiate that's in there causing the overdose will ultimately have a half-life and gradually come through the liver and the kidneys and get filtered out, but you have to keep giving the Narcan until that level has diminished to the point that they're no longer having the problem. Once the patient has the overdose under control, we're not looking to just send them home and say, okay, if you do it again, come on back in. That would be as ludicrous as the first scenario. We need at that point to get the person into the proper treatment channel, because there are multiple different channels that could be pertinent at this point in time. Getting them into the right treatment at the right time becomes the next step after treating the overdose. For the general population, my feeling is that if you have a family member or loved one who is known to have an opioid use disorder, that person should be able to get a prescription for naloxone to have on hand. You have to remember that most people who are using opiates use in either a group or in a multiple person setting, meaning 2 or more people. But most of the people who die of an overdose, when we find them, they're found alone. So there's a mismatch here. Most people are using with somebody present, but most people die alone. Well, the obvious thing is that the person overdosed with somebody there and the person got scared and everybody left. Those people need to have access to naloxone is what the goal is here.